Afternoon, everybody. Welcome to this is the second session of the Value and Health week set up by Life Sciences Hub. We're going to be talking to you today about using outcomes to improve access for patients based on the greatest needs. I think you might get a picture of me in a moment. My name's Dave Minton. I'm a GP and I'm one of the Associate Medical Directors for the Value-Based Healthcare team in Nara and Bevan. And alongside me is Bonnie Overland, who's the Deputy Divisional Director for Urology. Bonnie?
Thank you for the promotion, David. I'm actually the Assistant Directorate Manager for Urology with the Nara and Bevan University Health Board. Good afternoon, everyone.
Okay, so what we want to talk to you about this afternoon is a piece of work that we've done around urinary flow within the urology department. What we know is that 50% of men aged 60 and above have urinary flow problems, and what we've also know is that most of those that get referred in by GPs get discharged at their first appointment. So the first step that we'll do is Bonnie's going to talk you through the aims of the project that we've done together.
Thanks, David. The primary driver for looking at this particular cohort of patients was the excessive waiting times experienced by the patients who were put onto this pathway. At the time we looked at it, the patients were in excess of 36 weeks for their first appointment. The referral to treatment target for urology is 26 weeks, and we were achieving 95% of that, but this particular cohort was waiting much longer than that. So what we wanted to do is look at the reduction of the appointments in the urinary flow, discharge without intervention, rapid access for the most appropriate care pathway for the patients who actually needed to come, and improve the patient outcomes, and also enable clinicians to monitor the symptoms and well-being. In urology, we're very flexible and able to switch and change clinic slots to accommodate fluctuating demand, ensuring the capacity for those particular patients, the urgent suspected cancers, the very urgent and the multidisciplinary patients. However, this particular subspecialty, urinary flow, this was a one-stop appointment, so it's much more difficult to try and accommodate these in a normal clinic setting. We approached the value-based healthcare team to see how, if with the use of technology, we could improve the way we manage these referrals, including the pre-appointment questionnaires that we sent out to these patients, which they completed before they came, which included a prostate symptom score, a sexual health questionnaire, and a 3-day bladder diary. If the patient could provide all of this information electronically, this could be virtually reviewed by the consultant and maybe reduce the demand for the clinic. Based on the early statistics, by using a scoring matrix consultant used in the clinic setting, the score could be virtually reviewed and the patient managed according to that symptom score. So it would maximise, this would then maximise the resources that we had. It meant that those with mild symptoms wouldn't necessarily need to come to clinic. They could be given the appropriate advice and be discharged. Those with moderate symptoms, again, they would receive advice, maybe some lifestyle changes, maybe some medication, and perhaps repeat the process again 3 months later. And then those who were urgent, obviously, they were given an appointment within 8 weeks. Patients were advised they were on a virtual pathway by text and a letter, and information sent with the IPSS and the sexual health questionnaire, and they were told a virtual appointment date had been set for 6 weeks ahead. The patients were advised, they had 3 weeks to respond, and then they had a text 2 weeks later if they hadn't responded. And if they still hadn't responded, when it came to the virtual clinic appointment, the consultant would then discharge those patients or give them an appointment depending on their outcome. And then the GP and the patients were notified. And I'd like to put you to a small video now to explain how we did that. It'll take a couple of minutes to set it up to make it start, so we might go quiet for a little minute. Follow-ups. If I can, just for urology, I do demand a capacity modelling consistently every single week, and at the moment we are following patients up annually, biannually, when they don't necessarily need to be seen. You know, you could be seen in clinic today and the consultant will say, I'll see you in 2 or 3 years' time. If we could manage that differently, these patients wouldn't need to come back. We could manage it virtually, and they'd only have to come in if they needed to, if they were symptomatic. At the moment, we're following up whether they are or not.
The follow-up management product is all about taking patients' care and changing it from being time-based to need-based.
Patients are invited to complete a form via text message or email. They complete their form online on their tablet or mobile. Once completed, the clinician is informed and reviews their form, and off the back of that makes a decision whether a follow-up appointment is needed or not. They then directly message the patient about their assessment and the outcome, keeping the patient in the loop of whatever is going to happen.
I think remote monitoring, particularly using something like the doctor-doctor platform, will enable us to have fewer patients coming to clinics, which then frees up our own time to see more patients in a more flexible manner. To the other side of the spectrum, those with severe symptoms are seen much quicker, so that if they need to have surgery, then that can happen in a very timely fashion.
For me, the attraction is to be able to signpost our breast patients to either a physical face-to-face appointment or psychological support from their breast care nurses, or no appointment at all, which has advantages in that they're not having to take time off work, they're not finding it difficult to park, they're not becoming anxious when they return to the breast unit where they were diagnosed with their breast cancer.
Clinicians, they don't necessarily just want to do something because it saves money or it saves hospital time. They are aware of that, but actually a key driver is patient care, and actually if they can still give patients a better experience and a better journey, then they're all for that.
My name is Sibby. I'm the mother of 2 daughters, and I was diagnosed with breast cancer last October. So to come for a radiotherapy session here, it takes half a day. It takes half a day out of your timetable. And most people, whether you're travelling public transport or driving, the challenge driving is finding a parking space, getting stressed, being late, the traffic's awful. One of the things about cancer is that loss of control. So it's happening to you, and a lot of people find that very difficult to deal with. And so just getting some semblance of control back is really important.
I think as we see an increase in the demand for healthcare and ageing population, we'll see that actually the provision of effective follow-up care and the management of it will become increasingly important. The demand really is going to be enormous across our population and other populations.
What's really exciting about the follow-up management product is we're beginning to build what I think is the future of healthcare. Across the globe and in the NHS, we're beginning to recognise that there is a fundamental challenge with supply and demand. And what the follow-up management products allow us to do is it allows us to fundamentally change that equation.
Go to other specialties that have done it, go to other health boards who have done it. Come and speak to us. We'll show you how well it works.
Okay, so that video shows what gives you a snippet of the view of doctor-doctors, a platform that we've procured as a health board. And the next slide is when it comes up. Hopefully, you can see. It shows you what we then moved ahead. With the change in the model that the urology department had previously and what they moved forward to now. So you can see at the bottom half of this slide, you can see what the old model was. So the patient would come and see me as a GP, be referred, and would then be sitting on a waiting list for around about 40 weeks before being seen and assessed by the consultant. Now, as Bonnie's already said, then at that point they would be given the same questionnaires that we've suggested that we send out electronically. And so from a governance point of view, we're asking the patient exactly the same questions that they would have been being asked when they came into clinic. Now, the new models is the referral comes in, is assessed in exactly the same way by the consultants as the referrals are processed, the decision is then made either from, if the GP letter states it's clearly very, very severe, then it might be seen quickly, but the vast majority will then be sent a text with the patient-reported outcome measures as described by Bonnie attached to that. They'll also be sent a letter saying this is what's happening, as Bonnie's already said. And if there's no response within a couple of weeks, then they'll be sent that again. The idea of this, of course, is that then they're being assessed first up in the same way as they would have been in clinic at about 6 weeks, possibly earlier. If the symptoms then are severe enough that they require an appointment, then they will be sent that appointment urgently. The service never had a problem with capacity for seeing patients urgently, but what was often happening with patients with these symptoms is they tend to be referred as a routine. So we were missing out on those that needed to be seen quickly. If the PROM score comes back suggesting that they're mild or symptoms, then they would be discharged back to the GP with a letter. The letters being sent was worked on with the patient reference group and also sent through the local medical committee to check that primary care were happy with it. I had a couple of tiny changes with both of those, but nothing great. If the symptoms are moderate, then they would go on to the remote pathway, which we'll show you on the next slide. So what happens then with the remote pathway is that the patient gets sent their PROM, and they've got moderate symptoms, and so another PROM will be sent a couple of months later for them to fill in, and if those symptoms remain moderate, then they'll be followed up again. If the symptoms are slightly worsening, then they'll continue to be followed up. If they're improved, then they would be discharged, and after 3 or 4 appointments, if they're stable, then they would be discharged with treatment if necessary, with advice to both the patient and to the GP. And I have to say at this point that we've only had a couple of PDSA cycles within this, so all the data that we're going to be showing you in a little bit is all from December last year. We were due to look at this again in March, but something else happened. I can't remember what it was, and so it's all gone slightly stopped. And so this, now what we're going to show you now is this video version of that, which is far more entertaining than listening to me talk, to show you how patients would show it. And this is back to the hipsters we had on the first slide. Okay, before I go on to this slide about the results, we've got a question that's come up in the sidebar. I'm going to break the rules and answer this now, but I think it's relevant to this point. We've got a question saying, how have you overcome the technology barriers for patients not being able to access the electronic questionnaire? At the start of this, we send a letter to the patient as well, and within that letter and the patient information, which has been agreed, as I say, through co-production, it says, if you have any problems with filling this in, please contact the service, please, and we'll either send it out by a paper or just book you in for an appointment. If you don't want to fill it in, then people can just wait as they would have done beforehand. So that's the way we have come across that, and that's been pretty effective up until this point. So the results of what's happened with changing this process at this stage, and as I say, this is data which is up until December last year. The expectation would be that 60% of patients' PROM scores would evidence that they have mild or moderate symptoms, and that's based upon the 60% being discharged at first appointment. What we expected to find was that sort of 30% of the problems coming through would enable the clinicians to confidently say that those symptoms were enough that we didn't need to put them in for an appointment, and that's really allowing for natural caution, I think. We sent, by the time we looked at this at the end of December, 145 proms had been sent out, so a decent number. Of those, the results coming back, 60% had been put within the severely symptomatic category, so we're given appointments within 8 to 10 weeks to be seen. 27% were moderately symptomatic, so went on to the remote monitoring pathway that I've just described to you, and 13% of those were mildly symptomatic, so were discharged back to the GP with advice for both the GP and the patient on how to manage their mild symptoms. That's possibly slightly lower than we would expect, but for the reasons that I've already said, that there would be an element of caution. I have to say, from a primary care point of view, I was very pleased that there's only 13% were mild, so at least we're sending appropriate people in, it seems to be, to me, and we would have looked at more data by now, but we haven't had a chance to have another meeting because of COVID. So the challenges that we came across within this was that we need to look to streamline the process that we've got, because the DNA rate, so the not attending or not, I suppose did not answer is probably the correct way of looking at this, was up to 18% compared to the outpatient DNA rate of patients not turning up is around about 11% for urology. So we need to look at that, and I'll bring Bonnie in a moment to explain what they did there. There are two ways that as a value program we go about new projects. We either look at a single clinic and use that almost as a pilot site to see how it works, or we go across the whole pathway. And what we did here was we looked at all the clinicians for Euroflow, because that's what the service wanted to do. But unfortunately, there are a couple of clinicians who were slow adopters, shall we say, who were booking patients into appointments despite their symptoms. So even though the proms were coming out showing mild and moderate symptoms, there were still people being booked in. That was picked up at the first PDSA cycle, and it did not happen during the second PDSA cycle. So that was good. So the engagement from the clinicians was extremely good. It's really important, therefore, that when we're talking to new areas, and this is what we did in great depth with the urologists, is to make sure that the clinicians involved know exactly how they're interpreting that patient outcome data. I'm sure there'll be questions later about what we think about using proms, or what I do as a clinician. Bonnie, do you want to come in and with the other challenges that you found?
Yeah, of course. Similar to that, as I said, it was varying practice within the clinicians. Even though they were given direct instructions on it would be mild, moderate or severe, there were variances on those. And even though they were mild in terms of what their matrix score was, they were severe in terms of other symptoms they were experiencing, so they were coming in anyway. I personally did the audit for the DNAs, and I was contacting the patients to ask why they hadn't engaged in the process, and there wasn't a clear outcome as to what the reason was. We said the information leaflet quite clearly said if you don't want to engage in the process, you want to do a normal pathway. If you're struggling to fill the information, or if you just want some advice, please ring us, and they weren't engaging in that. Even when they'd received their DNA letter, and their GP had received their DNA letter, and we would say the information leaflet said, again, ring us, they weren't ringing us, but I couldn't get any clear indication as to why that was. But obviously that's something we'll look at when we do the next PDSA, and we'll take that forward on that. Thank you. So then it's a bit of a busy slide, this one, I'm afraid. So this is the reality of how we've compared our new model to the old model. So in the old model, we had an RTT, as we've already described, so referral to treatment time of between 36 to 40 weeks, sometimes greater than that. Within the new model, you've got patients being assessed and or seen within 8 to 10 weeks in the main.
The virtual clinic time is obviously a lot shorter. It's much easier for the consultants to look through the problems than it would be when seeing people face to face. So it's 5 minutes as opposed to a 20-minute appointment, so they can obviously see many more. The requirement to travel, and you really don't want to go to the Royal Gwent if you can help it, because the parking is an absolute nightmare, as was said on that video earlier. So there's no need for them to travel, and there's obviously a socio-economic benefit. Most people, when coming into hospital clinic appointment, would need to take half a day off work at least. We haven't managed to actually measure that, but it's something that we're looking at wanting to do within the future. The patients within the new model are actively monitored throughout the pathway every couple of months, whereas in the old model, somebody would be referred by a GP and then would likely have no monitoring going on during the time when waiting for that appointment at all. So we can find out where we've got patients who are potentially deteriorating. We needed to put a little bit more admin support in for the department to be able to do the bit of additional work that is involved in this, but under half a whole-time equivalent admin support as an additional cost for the improvement that we're getting for patient care here. I think it's a no-brainer that it's worth the additional input. We, in both the new and the old model, and this data is from September to December 18 quarter in 2018, and then the same quarter in 2019. So there were no breaches of the Euroflow 36-week target, which is the hospital's target to hit. But in the old model, that was because we were spending money on waiting list initiatives, and Bonnie will be able to tell us exactly how much that is in a moment. There were, with the new model in place, no breaches in meeting the 26-week target, and that's across urology. It's not across just urinary flow. In the old model, there were 75 breaches of the 26-week target, which is the Welsh Government one. And in the interests of transparency, we've put the number of patients awaiting new appointments on here as well. So there were, nearly 800 patients fewer waiting a new appointment. So the 145 that we've moved out of the routine waiting list through doing this piece of work is not accounted for everything, but it certainly made a large difference from the data that we've got.
Okay, so we started to look at the benefits that we were getting from running this pilot. As we said in the video, we're seeing those with the greatest needs first, which is actually paramount for the patients. Quicker access to care and treatment for those patients who need it most, and better monitoring of those patients. The money that's been saved by not doing the waiting list initiatives, I can't tell you exactly how much we spent doing those, but it was roughly 3 clinics a week, which worked out about £3,000 a week, and we did that for a couple of months, to be honest. And the data that we collected is reusable data.
So you've got wider benefits of it as well, outside of just the urology department. I mean, I think we can confidently say that this approach works. We've been collecting problems in lots of different clinics, and we've been using them in active patient care for a little while now. And we feel that this definitely does work. This particular approach can certainly be replicated across almost any condition-specific pathway where you're using questionnaires for patients to assess them, and this happens a great deal. I know that the urology department are thinking about trying to do this again in continence clinic. We've had conversations about using this in asthma as well. So it is a replicable method of doing things, and we can go to moving, particularly as the way the world is moving at the moment. We can certainly start to help services do things remotely using this approach. There's also the potential larger benefit over time that this would lead to smarter referrals out of primary care. We're also looking at trying to do this within primary care, although it's a slightly more difficult thing to do. But I know there's a talk later in the week about value in primary care. But as the GPs understand that the patients that they're referring in don't necessarily need to be seen, then the referral rates should start to go down. We've certainly seen this when we've used advice lines from consultants for GPs, that people will start to ask the questions and then eventually will stop asking the questions because they've learned how to manage things. So that's the bit that we've finished talking. Our intention within this was to try to make sure that we used up sort of the first 25 to 30 minutes of this, hoping that we could stimulate a debate and get a lot of questions from you. And I suspect that I'm now going to be on screen, you poor people. So we've got a few questions coming up on the side. So we'll start off with the first one, just so I can throw Bonnie in first. So there's a question here saying, what advice, the top 3 things, would the team give to other urology teams wanting to start on the journey? Over to you.
Oh, right. Okay. Oh, that's a
Do you want
difficult
to think
one.
about that and we'll come back to it?
Yeah, please. Yeah.
Okay. There's one in here as well saying, how accurate were the questionnaires at identifying the most severe patients? Sensitivity and specificity. They're validated questionnaires, which are the ones that are being used across all Uroflow clinics, so they're the same, being used everywhere. So they are the accepted questionnaires to be being used. So they're considered to be the best. I think it's fair. Back to Bonnie for the 3 things.
Yeah, still working on that one. I think for me, as I mentioned in my earlier bit, was about the information leaflet. I think making that clearer, perhaps giving the advice for the patients to ring in, simplifying some of the information that we sent out. I know we found the bladder diary particularly difficult to replicate, and I think it's looking at that with IT. And 3. Probably engaging with the clinicians initially. We worked with Mr. Adam Cox, as you saw in the video earlier, and 5 of his colleagues. And I think because we had the variances in the outcomes, I think it's making sure that we pinpoint that properly at the beginning, making sure that we deal with that and score it correctly, if that makes sense.
Certainly does to me. There's a couple of the questions here with 2. I'll roll them into one because they're essentially asking the same thing. So has there been much pushback or any complaints from patients about not seeing consultant face to face based on a questionnaire? And are you looking at what patients think of the new model alongside? So that's asking the question about whether we're doing PREMs, so patient reported experience measures. We have done that. We did that in the first PDSA cycle, and there were 2 complaints within we had 70 patients, if I remember rightly, in the first PDSA cycle, and there were 2 patients that complained that they just wanted to see a consultant. What we picked up from that, we wanted to then try to marry that up to whether that person had severe symptoms or mild symptoms, because obviously either of those could be a reason for the patient saying that they wanted to be seen. And we were planning to do that in the next one, but obviously one thing and another happened. Bonnie wanted to come in.
Yeah, I think one of the experiences that came back from one of the gentlemen that we spoke to as well was he had difficulty in filling in the information remotely, and he'd asked his grandson to support him, and when he was uncomfortable filling in the sexual health questionnaire at that point, so that was a little bit difficult. So that's something we when we looked at it for the second PDSA, we decided that we'd say to the patients, you don't have to fill that part in if you don't need to. So that was just one thing that came back as part of that.
Okay, there's another one on here saying, is this triage process something Iron Bremen plans to use in other specialities? Absolutely, yes. This is something that we've been using PROMs in several clinics to look at where we need to see patients more sensibly. So we've done that within heart failure, we've done it with inflammatory bowel disease. We're looking at doing it in rheumatology as well. We've had conversations about considering doing it in asthma as well. So yes, we're actively doing that. What we haven't done much at the moment is at the referral point, but with the success of what's gone on with this one, then yes, that would be something we would be looking at doing in the future. Got one of the other questions I had in advance of this was about, as a clinician, what do I feel about using PROMs rather than not using PROMs with a patient in front of me. So I've had an opportunity to reflect on this one a little bit more because I got it before we started, and my thinking on it was that anybody who's worked in a clinical setting, or indeed anybody who's tried to sell anything, the key, if you know what it is that the person in front of you wants to talk about, then you can target your consultation or your conversation far more sensibly. And the advantage of filling in PROMs before a patient comes in to see you is you get that opportunity. You don't talk to them about what it is that you want to talk to them as a clinician, but you talk to them about what the patient wants to talk about. And that, I think, is the central point that we've always used in the Valley team about where we can use PROMs within direct patient care. It's always been the centre of it. We've got any other questions? Sorry, I'm just looking down. There's one here. The team see any opportunities where technology might add further to this pathway, such as something like point of care testing. I think for this particular pathway, I don't think point of care testing would come in usefully here, but there's certainly the opportunity to use this type of approach when you're monitoring bloods or you're monitoring patients, and you could do that via point of care. You could potentially use it in things, for example, you could potentially use it in diabetes. You can use it in, we've had conversation about using it for prostatic disease as well. I think there's a tech question about whether the questionnaire link in with the electronic health record or is it standalone. That's a challenge, shall we say. Trying to get the IT systems to talk to each other has been a huge challenge we have for a long time, and it's something that we're constantly working on. And I haven't got any other questions in my sidebar. Bonnie, have you got anything else you wanted to add?
No, I think we covered everything off. Thank you very much. If anybody's got any questions sort of following this, then by all means, if they want to send them through, we can try and answer them a little bit later on, if they think of anything. Absolutely, we'd be more than happy to have any questions either specifically on this or any questions about our value programme more broadly. Please do send them in and we'll respond to them electronically. But if we haven't got any other questions, I think that largely finishes off. I just at the end of this want to remind everybody that there's still 23 more events going on this week, so if anybody wants to register for any more of those, then I'm sure the Life Science Hub will be delighted for you to do so. I hope you've enjoyed our presentation to you today. I hope you found it informative and useful. I'd like to thank Bonnie for joining us, and Priya and the rest of the team for hosting it and getting everything running up and well. And thank you very much. Thank you for everybody who's listened in. Thank you, and thank you, David.